Good afternoon, everyone. It's a pleasure to welcome you to today's mini symposium session 1.4, titled "In the Fight, Advancement and Challenges in Cervical, Breast and Prostate Cancer Prevention, Screening and Treatment." We are honored to have this session moderated by Professor Mahika Senavikrama, a seasoned expert in the field. Professor Senavikrama is a board-certified public health specialist and an esteemed academic researcher with over 23 years of experience in curative, preventive healthcare teaching and research. She serves as the head of the Department of Community Medicine at the Faculty of Medical Science and is also the director of the Center for Cancer Research at the University of Sri Jayewardenepura, Sri Lanka. Her dedication to advancing cancer research and her leadership in public health make her an ideal guide for today's discussion. I'm glad to invite Professor Mahika Senavikrama to open the session. Professor Senavikrama, the floor is yours.
Good afternoon, everybody. Welcome to the mini symposium titled "In the Fight, Advancements and Challenges in Cervical, Breast and Prostate Cancer, Prevention, Screening and Treatment." This mini symposium brings together leading experts to discuss the advancement and challenges in the prevention, screening and treatment of prostate, breast and cervical cancers with a special focus on low and lower middle income countries. These cancers represent some of the most common malignancies worldwide, causing significant morbidity and mortality. In low and lower middle income countries, including regions of Asia and countries like Sri Lanka, the burden of these cancers is particularly acute, exacerbated by limited access to screening, early detection and comprehensive treatment options. Prostate cancer, the second most common cancer in men, poses unique challenges related to its diagnosis, particularly in regions with inadequate access to screening tools such as prostate-specific antigen testing. Globally, breast cancer remains the most common cancer in women, accounting for 2.3 million new cases in 2022. In many low and lower middle income countries, late diagnosis and limited treatment resources contribute to higher mortality rates. Similarly, cervical cancer, which is largely preventable through vaccination and regular screening, still claims over 340,000 lives annually, with 90% of cases occurring in low and lower middle income countries. Today's session aims to explore the epidemiology of cervical, breast and prostate cancers, outline public health strategies to reduce the impact of these cancers, evaluate the effectiveness and accessibility of screening programs, and to identify disparities in prevention and treatment access for these cancers across different populations. We have three distinguished panelists with us here today. Professor Isha Prematilaka, Dr. Kanchana Vijayasinghe and Dr. Diana Constanza Pellido will share their experiences and insights during this symposium. Professor Isha Prematilaka, who is seated right me, is a specialist in histopathology with over 30 years of teaching experience and more than 20 years as a board-certified consultant in public and private sectors. A professor in pathology at the Faculty of Medical Sciences, University of Sri Jayewardenepura, an honorary consultant histopathologist at Colombo South Teaching Hospital. She specializes in gastrointestinal and urological pathology. Trained in Oxford, UK, Professor Prematilaka has published extensively, co-edited in Sri Lanka's National Guidelines in Histopathology and contributed to the National Guideline on Early Detection and Referral Pathways of Common Cancers with a focus on prostate cancer. Dr. Kanchana Vijayasinghe is a board-certified general surgeon with a specialization in breast surgery and over 15 years of clinical experience across public and private health care. She serves as a senior lecturer in the Department of Surgery, Faculty of Medical Sciences, University of Sri Jayawardhanapura, and practices as a visiting surgeon at Colombo South Teaching Hospital. Dr. Vijay Singh is the Secretary of the Sri Lanka Society of Breast Surgeons and has published research on breast diseases. And Dr. Diana Constantino Pelido holds a Master's in Public Health and a Master's in HIV/AIDS, with over 14 years of experience across clinical practice, policy research, and program evaluation globally. She has led health and nutrition integration in humanitarian settings, focusing on sexual and reproductive health, gender-based violence, maternal and child health, nutrition, and mental health. Formerly acting director of programs at Save the Children, Colombia, she now serves as Global Humanitarian Technical Lead for the International Planned Parenthood Federation. Now, allow me to give you a brief overview of our session. First, Professor Isha Prematilaka will present on prostate cancer, focusing on the importance of screening and evolution of the Gleason grading system in guiding treatment strategies, particularly in resource-constrained settings. Then Dr. Kanchana Vijayasinghe will talk about breast cancer, focusing mainly on symptoms, the importance, and the methods available for early detection. Finally, Dr. Diana Constanza Pelido will address the urgent and unmet need for cervical cancer prevention in humanitarian settings, where the lack of infrastructure and healthcare access exacerbate the already significant burden of disease. These presentations will offer valuable insights into the complexities of cancer management in low and lower middle income countries, while exploring innovative approaches to prevention and care. After each presentation, we'll open the floor for questions, allowing you the chance to engage directly with our experts. With that, let's warmly welcome our first panelist, Professor Isha Prematilaka, to begin.
Thank you, and thank you to Reprosex for having me. Also, thank you for including something about men. So prostate cancer. This is a cancer which occurs mostly in older men over 50, which with a much higher incidence over 65. It's the same in other parts of the world as in Sri Lanka. And it's not a cancer that is involved with a lot of risk factors which you can prevent, but there are some known ones like family history. If a man has a father or brother or close relative who was diagnosed with prostate cancer at less than 55, or if they have family members with cancers associated with BRCA gene mutations like breast, ovarian or pancreatic cancer. It's known to occur more in African Americans, and it's less in our part of the world. And there are some dietary factors vaguely associated, like increased red meat, processed meats, and less fruits and vegetables, obesity and lack of physical activity, and also chemicals like those found in cigarette smoke, vehicle exhaust fumes, DDT, and cadmium. So the early symptoms, this is a cancer that doesn't give early symptoms, right? So like the symptoms they do get somewhere in their disease are due to, obstruction of urine flow. And mind you, obstruction of urine flow is not just due to prostate cancer, it can be due to benign prostatic diseases. But it's important to make men aware that it could be a cause. So frequent urination, difficulty in starting urination or holding it back, weak or interrupted flow. Also less common, they can have burning sensations or discomfort in the pelvic area or blood in the urine or in the semen. Late symptoms are more severe, and if they have bone pain, you have to think whether it's spread to the bones. If they have swollen lower limbs, think about whether there's lymphatic spread. And then the general symptoms of cancer are there, like unexplained weight loss and tiredness. They can have erectile dysfunction. In the late stages, they can have loss of bladder and bowel control and complete inability to urinate. Treatment depends on risk stratification. There are several methods of stratifying risk. Most of them use the Gleason grade and the PSA and the stage of the disease. So this is a tumor, interestingly, which if it is slow growing, men can live with and die of other causes, right? So those are called low risk tumors, and they are offered what we call active surveillance, where they have routine checks for PSA or digital rectal examinations or biopsies at regular time intervals. This is a bit of a problem in our setup because in the state sector, people might just trot off and never come back again, right? So still for all that is the option for low risk cancers. And higher risk cancers, in our country, it's mostly radiotherapy because there are too many surgical complications from radical prostatectomy. But in the West, where they have perfected this more, there are a lot of radical prostatectomy still happening. And if it has spread, you can give other treatment options. Right. Now I come to my first key point. Prostate cancer in Sri Lanka is probably still underreported. Professor Chandu D. Silva back in the 90s published a paper on this, that it's underreported. And things have improved since then. But even in the 2021 statistics, it's the 5th commonest cancer in Sri Lanka, whereas in 21 in Western countries, it was the 2nd commonest. Now, in USA and in UK, it's the top cancer in men, right? So I still feel that we're missing something, right? It's only 7.5% of the cancers in our men. This is the latest data available, right? Now, PSA testing is a double-edged sword. There are good things about PSA and bad things. The good things are that it's known to reduce mortality in high-risk populations. It's just a blood test. And there are newer modifications like PSA density and velocity, which are supposed to increase accuracy. That being said, it's known to have false negatives, false positives, interracial differences, interlab differences due to the testing technique they use. And okay, this, as I said, it can be a slow growing indolent cancer. But if the man knows he has a cancer, then he's going to be anxious and go ask for various other investigations which may not be necessary, right? PSAs are expensive. In this country, in the private sector, it's like 10 to 11,000 bucks, right? And also, the cutoff point, it has always been traditionally 4 nanograms per ml, but there is debate about this cutoff point. It may depend on the age, etc. That's my next point. Most of our cancers, prostate cancers, are high grade, unlike the West. Okay. Now, what's grade? It's defined by this thing called a Gleason score, right? And what we do is we look under the microscope for these patterns that we see, right? And then we, it's a combination that we give of 2 patterns, usually the predominant pattern and the worst pattern. Now, of these 5 patterns that Gleason originally divided it to, nowadays we don't even call the first 2 cancer. Right, so then we have basically 2 patterns we are dealing with. 3 patterns. Right. Now, grade groups are a newer modification by the WHO, where they took all the possible combinations of the Gleason scores and divided them into 5 grade groups. Okay, this is simpler to do. Okay, and it provides better risk stratification. You will notice that the 7s have been split. Okay, with the ones that have predominantly pattern 3 cancers and ones that have predominantly 4, because they behave differently. So they are it's more accurate in risk stratification. Also, imagine telling a guy you have Gleason score 6 cancer out of 10. He thinks, oh God, I'm dead, right? But it's actually the grade group 1, which is the most indolent cancer. So grade groups reduce over-treatment because they can better distinguish aggressive and non-aggressive cancers. But nowadays, we are still evolving, so we give both in our reports. Some urologists use Gleason score still for risk stratification. Right? This is the future. Molecular tests, artificial intelligence for grading. Even now, there are modules online which do AI grading of prostate cancer. But this is still not in clinical use. Right. This is an ongoing study, and at the moment we have about 345 cases from 4 centers, and our mean age is on par with other studies in Sri Lanka, older studies. And this was a question I had when I came back from UK, because in UK you have very small quantities of very low grade cancer, and here it's teeming with high grade cancer. So I wanted to see whether this is actually true, and so far it seems true, because 20% only are Gleason score 6, and the rest 80% are 7 or higher. Grade groups, you can see it's equally spread across the grade group. Now we compare this with a study from Colombo North. Gleason scoring has evolved, so you have to compare it with newer studies. And then our findings are similar, and you can see that the Gleason score 6s are less than the higher grades. Comparing it with a study from UK is different. Okay, this is Dan Burney's study, and his one is in blue, and you can see that they have far less of the grade group 4 and 5 cancers, and we compared with our grade groups, which are going across all the grades. My next point is that most people don't die of their prostate cancer. This is 2021 from Sri Lankan Cancer Control, NHS UK and CDC USA, and you can see the death rates are pretty low, especially in UK, right? So, but in our country, this is NCCP data, and the prostate cancer death rate is slowly creeping up, whereas in the US and UK it is definitely going down. So now we have a lot of high risk cancers, high grade cancers, right? Even Balagovi et al. Did a study in Jaffna, found 80% of their cancers were high risk and less deaths. Why? There are probably several reasons for this. One is grade migration. As I said, Gleason grading has evolved, so some of the things that were lower patterns are now higher patterns, so then the overall grade grows up, right? But that's a small factor, because even the older studies had less low grade cancers in our country, right? But the more important factors are, this is a slow growing cancer, so most of them probably don't die of it. We don't know how many cancers we actually have, right? And there is a severe dearth of follow-up data, so we don't know whether they died of them or not. In 2020, I was happy to be a part of this, and it states that PSA-based screening should be done if the man is over 50, or if you want to do it in a younger person, they should have strong risk factors. If the PSA is high, refer to a specialist for further evaluation. Avoid over screening, that's stressed. Okay, balance the benefits with the potential harms. And when it's confirmed, refer to oncology immediately. Now, that's my last key point. It's really difficult to do prostate cancer research here, because in the government sector especially, there are very few clinical databases being maintained. We can't even get the PSA values of patients, right? And even the data we have is not uniform. People are re-stratifying in various ways, testing PSA in various methods, etc. And there is no integration with our pathology data or the radiology data. So, basically, the public and primary care physicians should be educated that although prostate cancer is mostly indolent, there can be aggressive tumors, and the purpose of screening is to catch those aggressive tumors and not to treat the ones that are indolent. Over-screening is not advised. We have perfectly good guidelines which should be followed, and although it's not strongly linked to a lot of risk factors, things like smoking, which are preventable, should be avoided. And for tertiary care centers, it's time we established good databases, and I think the colleges have a role to play in establishing a dialogue for this. And those databases should be comparable. So there should be standardized PSA testing methods, radiology reporting, biopsy protocols, pathology reporting, risk assessment, and treatment protocols. Thank you.
Your presentation brought light some critical aspects related to the prostate cancer, particularly its diagnosis. Our panelists here are to provide further insights. So please take this chance to ask questions from Professor Isha related to her presentation.
I think so, and like the lower urinary tract symptoms, okay, as I said, it could be benign, but men tend to ignore this, put it off, and I have a hunch that they are presenting late. Yes.
So what do you think would be a best strategy going forward, maybe with them?
Well, public education is good, and this can be done in a variety of ways. Pretty simple. I mean, not just having like you have breast cancer campaigns like that. Okay, okay. So yes, yes, right. So other than having little meetings in person and education webinars and stuff, you can also do. One thing we need to do in this country is partner with the primary care setup, because that's where the rather illiterate, less educated people are, and they are the ones that we can't reach, and they are the ones who present late, right? So partnering with the primary care setup is important. And then of course there's social media nowadays, which can use celebrity endorsements, influencers, the list is endless, right? And I mean, you can do in front of my friends who's a urologist was saying, you can just put stickers on public urinals. You see, you have difficulty in urination, go and see a doctor. It's very simple, right? Actually, there was a very interesting project done by a student in design, where they designed a beer tower, where the more beer you take out, the less comes out. So it's like decreased, like an urine obstruction. And then it says, if you have this problem with urination, contact your doctor.
We should put it in the vase. Thank you so much.
So you have given the mean,
Yes.
some 72 years
Yes.
or something like that.
Yes.
So I presume that the age also a major factor for the prostate cancer.
It is,
So,
because
yeah, high
like
correlation.
Yes.
Yeah.
It's
So could
less
yeah.
than 50 is extremely rare.
Yeah. So could you tell me that the median of age group, whatever that 45 to
Yes,
93?
we have. This is like an ongoing study. We haven't
Okay.
really looked at the median yet.
Yeah, that
Yeah,
will
but
give us the-
yes, exactly.
Yeah.
But we did notice that a large chunk of them were over 65.
Absolutely, yeah. Because
Yes.
age is a major factor. Yeah,
Yes.
thanks.
Okay, thank you, Professor Isha. Now, I would like to invite our next panelist, Dr. Kanchana Vijayasinghe.
Thank you, Mahika, and thank you very much for inviting me for this session. So I think we're going to move on from prostate cancer to breast cancer. And I would like to start off by saying Prof. Isha said that although prostate cancer is quite, it's not very common, but the real cancer-related deaths are uncommon with prostate cancer. This is completely the opposite when it comes to breast cancer. Today in Sri Lanka, the highest cancer-related mortality among women is due to breast cancer. So let's see what we can do about this. Right. So I'm sure you all know that breast cancer is the commonest cancer among women globally. This is the same in Sri Lanka. The incidence, as you can see, is on the rise. Couple of years ago, I said in similar speeches that we had about 3,000 new patients diagnosed every year. Now it's close to 6,000 cases per year, so it's on the rise. Nextly, you can see when you look at the cancers among females in Sri Lanka, breast cancer is at the very top, and it is very unlikely the other cancers are going to beat it, because if you look at the incidence of its rising, breast cancer has a very steep rise. And when you look at the age group which the breast cancer affects, this chart very clearly shows that it is common after 40 years, but you do see breast cancer in young females as well, and this is also on the rise. Couple of decades ago, we saw many older females with breast cancer, but we see younger females at a higher rate now. When we look at the WHO projection, you can see in the South Asian region, they are projecting that there will be a 50% rise in new breast cancer cases over the next 2 decades. And look at the next one. It shows that the breast cancer related deaths will also rise. So there's a dying need to do something about this. So to address this issue, I generally put this slide to show how we can beat breast cancer, and there is a silver lining in the cloud. So just like any other cancer, like prostate cancer or any other cancer, it starts from one cell, and it will start spreading locally, and it will go out into the body. So you can see we have a stage 0 in breast cancer to 4, and at the bottom you can see the survival rate. That is how well we can cure a patient once they present at a particular stage. Now what I want you to see is, if you look at stage 0 and 1, we can almost guarantee 100% cure rate. Whereas it keeps dwindling when it goes to stage 2, 3 and 4. Now where do you think our Sri Lankan women are commonly? We would love to see them in stage 0 and 1, but we hardly see them. They are commonly in stage 2, 3 and 4. So how can we, not only in Sri Lanka, any woman for that matter, how can we get that woman to present in stage 0 and 1? Because mind you, we don't have a vaccination. There is no way we can prevent from getting breast cancer. The only way we can beat is by early detection, and it is clear, because if we detect early, we can give you a near normal life back. So let's see how we can do that, and what are the challenges that Sri Lanka is facing. So the World Health Organization has given us 3 targets. One is, first pillar is, we have to promote early detection. It is quite clear from the previous slide, earlier we detect, better. And the second pillar is timely diagnosis. Can we diagnose this quickly and give a proper management as quickly as possible? And let's see how Sri Lanka is faring with these pillars. So as I said, so the first pillar was early detection. And we have 3 simple techniques for that. Self-breast examination, which is something the public can do. You don't need doctors for this. And I'm sure you all well versed about this. With self-breast examination, we can identify patients. We try to target to identify them at stage 1. Because most of the time, our women present with an incidental finding of a lump. When they are taking a wash, when they are taking a shower, they feel a lump. And that is a random, they feel a lump randomly. For that random lump to be felt, it has to be quite big. And they are always in stage 2 and 3. But if you know about your breasts, then you will be able to identify at stage 1. Same principle for clinical breast examination, getting a doctor's checkup annually, especially for women above 40. That will help us to identify at stage 1. But if you look at this picture, you see at stage 0, there is no lump. So there is no way a doctor or a woman can identify the cancer. And that is why we have screening mammography. A mammogram can detect a cancer, a breast cancer, even before it turns into a cancer, at a very, very early stage. So that is why in the developed countries, they offer this free of charge for women roughly above 45 years of age. Now, unfortunately, in Sri Lanka, I don't see this happening for the next 20 years or so. We will not be able to offer free mammograms because we have a waiting list for even breast cancer patients to get a mammogram done. But at Sri Lankan level, I still think we can go ahead with self-breast examination and clinical breast examination and try to target to see most of our patients in stage 1. So now, as Profisha said, we do in Sri Lanka have lots of campaigns. We have the National Cancer Control, we have other NGOs, charity organizations, doing so many campaigns. And I don't think, I'll hardly find a female who's not aware that breast cancer is the commonest. And they are aware about these techniques of examination also. If you look at this was a research that we conducted a couple of years ago on females diagnosed with breast cancer. Majority of them were aware about the technique. But for some reason, if you look at the numbers that were practicing, dismal numbers were actually practicing this. And this goes beyond all education levels. We are not looking at females who have failed O-levels or not gone to school. We are even looking at postgraduate degree owners not practicing the self-breast examination. And I personally think this is something wrong with our education system. For some reason, we don't expect any males, females to practically apply the knowledge. So somewhere down the line, I think we are just parroting out theory and we are not highlighting why we need to identify early, and that is to improve the survival. And also this study went on to find out, right, so the women, we inquired from these patients with breast cancer how long they stayed at home before presenting. And you can see about 50% of the patients stayed at least 3 months before seeking medical advice. So we need to address this also, because when you wait for 3 months, obviously you understand now that the patients will present quite late as seen in these pictures. So I think we as Sri Lankans have to look at the way we are setting up on breast cancer awareness campaigns. We need to see that they are practicing. No point preaching with lectures. So we went on to find out why these females are presenting late. What's the problem? And majority of them had fear of being diagnosed with breast cancer, fear of treatment. If you actually really listen to them, they are very worried about losing their breast. Because the current concept is they think breast cancer, I'm going to lose the breast. But that is not so. Now we can offer breast conserving surgery. So these kind of myths have to be dispelled. Other thing is, commonly the women put the family to the front. Their children's education, work, etc. and try to delay. So we need to address these issues. So the next pillar is, so fine, we have found a patient with breast cancer, we made a clinical diagnosis, how soon can we give the investigations, get the investigations done to a patient? So if you look at Sri Lanka, so to diagnose breast cancer, we generally need a mammogram. We generally have about 15 to 20 mammograms to the entire country. Colombo in the public health sector. So in the government level, in Western province, we have about 3 to 4 mammogram facilities, but when we go to the peripheral provincial provinces, we have at about 1 mammogram per province. To give you an example, practical example, a female patient came to Colombo South Teaching Hospital due to a connection with another healthcare worker. She was from a different province. She was given a 2 months waiting list for a mammogram. Clinical diagnosis was breast cancer. So she was diagnosed in August, was waiting for a mammogram in October. So she landed in Colombo South Teaching Hospital, got it within a week's time, and she was operated before October. Same with, as I said, same with treatment. Closer you come to the Western province or the provinces with better facilities, we give better surgical facilities, sooner surgeries, the treatments are done sooner. Further you are away, they have significant problems in transportation, financial issues. So these things make them delay their process of being treated soon, and the patients also feel reluctant to go and seek medication because of these problems and waiting lists. So 3 aspects that the WHO has mentioned to us, 3 pillars: early detection, timely diagnosis, and timely management. And I think Sri Lanka is still on the way to reach the optimum level, and we need to address these issues. Medical and non-medical all should get together and try to sort out this problem, because we, as I said before, breast cancer is the leading cancer among women, and we have a dying need to address these issues for our own women. Thank you very much.
Dr. Kanchana, that was an incredibly informative presentation highlighting key insights into breast cancer. Now the floor is open for discussion.
Doctor, but there is a 3 months delay for the patient
Yes.
from the time they found the lump to see you. Do you think is this something to do with your cyclical changes? Because, I mean, we have, during menstruation with different phases, we feel the knot, or like we feel like we have a knot, and then we don't. But how can we differentiate that, to a breast cancer lump? Because every time you feel like then you have a cancer, then you go to the doctor, then he said, no, it's just your cyclical thing. Then after that you become, we don't want to check it. You're shy to go back because of this. So I think I've heard of it a lot, but what's your solution for it?
I think that's a very good question, because when we advocate self-breast examination, we always tell that if you are a female who's having periods or menstruation, please don't examine your breasts just prior to menstruation, because we know, all females know, the breasts are very tender, nodular, lumpy just prior to menses. You start examining your breasts prior to menstruation, you'll have to go and visit doctor once a month. So you have no choice. So we clearly mention, if you're examining your breasts and you're having periods, you have to examine your breasts 1 week after menses. And if at that point you feel a lump, you need to get yourself checked. And it's okay to get ridiculed. Go and get yourself checked. Your health is your investment.
I have a little question, Kanchana. Now, you said that, people, they know about breast examination, but they don't do it. So, This is just a little example. There was an organization called Mituruela. They used to do this breast cancer education. And they used to take these public health midwives and get them to examine the women who come. And like they find like 3 per session with lumps, 3 people with breast lumps per session. Like, so is there a way of doing that? Taking the mountain to Muhammad and, literally sending, when they come for other things, getting themselves checked.
Yes, we've tried that, at least to take a small hill to Mohammed. We've tried to get the midwives to go and check the breasts, especially when they encounter them during certain, like when they are screening for pap smear and etc. The thing is, the midwives are already inundated with work, so it has worked to a certain extent, but I think the females should take responsibility of their own health. We can't take that issue away. They have to do self-breast examination. The moment we hand it over to somebody, the females will think, right, I'll wait for my midwife. So I think it's a good, we tried that, but we failed.
Thank you, Dr. Kanchan. Is Dr. Diana Constanza Pelido. Dr. Diana, the floor is yours.
Well, about cervical cancer, you can see here that cervical cancer is the 4th commonest cancer in women globally, with about 600,000 new cases by 2022 and 350 cases of deaths by 2022 as well. 9 in 10 cervical cancer deaths worldwide occur in low and middle income countries. As you can see in the heat maps, both of the trends are in the south, right, in the global south. 90% of those trends in 2020 were located or concentrated in low and middle income countries. What about the estimations or the projections of the new cases and also the death by 2050? You can go through the Global Cancer Observatory from the International Agency of Research on Cancer. It belongs to the IARC International Agency, and it is closely in collaboration with the World Health Organization, so you can go through it and just play and navigate throughout the dashboard. It will give you wonderful information and projections about different types of cancer, including cervical cancer, breast, prostate, lung, etc. So by 2050, we will have around or more or less 1 million of new cases if we do not do anything to tackle the situation. Also, we expect that 400,000 deaths will be in place by that time if we don't do anything to intervene from the public health perspective. So also you can find this type of graphics and pictures and these figures from the the Global Observatory of Cancer from IARC. So you can do some comparisons between the trends in regards. You have in the x-axis the categories from the World Bank in relation with some of the countries are in high income or low income, and you can see the trend of the new cases or the incidence per thousand of people, of women at risk. Unfortunately, the number here, the percentage didn't appear, but by 2050, high income countries only will increase their new cases in 7%. In comparison with the low income countries, plus 152, if we do not do anything around there. So by 2020, the World Health Organization launched the Cervical Cancer Elimination Initiative, and it is driven by this global strategy to accelerate the elimination of cervical cancer as a public health problem. It has 3 targets, special targets that should be accomplished or achieved by 2030. So 90% of the girls should be fully vaccinated by that time, 2030. And they should be between the years of 9 to 40 years. 70% of women should be screened with a high performance test by 35 years of age, and again by 45 years of age. And the final target is 90% of women that has been identified with cervical disease are receiving any treatment. So you have a precursors lesion, you should be treated. And if you have an invasive cancer, you should be managed. Are we on track to achieve this commitment that all the member states that belong to the World Health Organization are working or not in this issue? Are we working or not in this issue? So it's quite difficult to find out this data. However, the WHO organization has launched some of the impact sheets, some of this data, and also in some peer review surveys that have been done throughout the world, reviewing and searching what is happening with the programs and with the surveys, such as the health benefit packages surveys that has been done by the World Health Organization. So you can find if the package, the comprehensive package is included in the health system or not in each of the countries that are committed to provide services, cancer services. So we have that 27% of the girls has been vaccinated so far. The last this number is taken from a fact sheet from 2023. So this is the last information that we have. Another information is that we have only, it was a review of the programs, this number. So we have that only 9 to 11% of women in ages between 30 to 49 years old in low middle income countries have been screened during their lifetime, against 83% of women in high income countries. So you can see the difference. Only 11% of the population. Can you imagine? I don't know. For instance, my country is a middle income country. I came from Colombia. Only 11% of the population has been screened so far. Against Belgium, which I'm living now, 83% of them have been screened at this moment. It's just numbers, trying to extrapolate it and put some examples here. The last one, unfortunately, is only in the global strategy. This number it came from 2020. So we do not have real data after 4 years of the launch of the strategy. So it says that about 30% of the low-income countries reported that they have a comprehensive care package, which includes pathology, surgery, chemotherapy, and radiology, and most of them, or some of them, they are using also palliative care. Again, 90% of the high-income countries, they have the whole package, against this 30% in low-income countries. But what happened in humanitarian settings? So a humanitarian settings is when a complex situation, for instance, a climate crisis related or a conflict or violent situation happens to the country and impacted the most important sectors, such as health is one of the first, shelter, also water, and finally protection. So what happened in humanitarian settings in regards of all type of cancer, but especially in cervical cancers? So approximately 84% of the 18 million people that have been forced in the last decade to flee their homes are hosted in low middle income countries, which are scenarios of complex and protracted humanitarian crisis. So again, I can put my country as an example. We have been facing the migration of from people from Venezuela. And in the border of Colombia, we are overwhelmed already. So we are fragile. We have fragile systems around the borders. Functional hospitals in Syria had available cancer treatment services, but only 46% of the patients with cancer in Syria had completed radiotherapy. So you can see that the trends are very different if you are in a humanitarian setting. Also, there are different factors such as demographic and epidemiological factors. Maybe we thought that because there is a humanitarian setting, it is not an epidemiological transition. So it is happening as well. So non-communicable diseases are also increasing in humanitarian settings. Why? Because they are not being treated, they have been being early diagnosed, and also we do not have the capacity to screen, to aware communities, etc. So if it's difficult in stable times, it will be even more difficult when you have a humanitarian emergency. Well, other factors that has been impacted, the possibility to treat and to diagnose early different type of cancer, including the cervical cancer, is also the awareness in humanitarian settings and the traditional approaches to provide humanitarian aid. More normally, we are providing primary health care to tackle communicable diseases, infections, also doing life-saving actions such as in SRH, for instance, in IPPF is working with the minimal initial service package, which means that we have a set of activities to implement in humanitarian settings or scenarios so you can life-save. Those are life-saving activities. We are not using, I don't know, it is quite expensive, and also the continuum of the care will be quite difficult to maintain in humanitarian settings due to the resources, but also the capacity to sustain it in time. But at the end, we have also this, it comes from the global strategy, so we have 3 main paths or 3 main pillars to tackle or to intervene this cancer, specific cancer. So the primary prevention, which aims to achieve the 90% that we saw at the beginning. So it's to improve the capacity of the health systems to provide vaccinations to girls and also to boys, and other different type of behavior risk actions and activities at community-based or also through public health programs. The secondary prevention is to use the screening with a high-performance test, which includes HPV DNA, cytologies, and also the visual inspection of the cervix with acid acetic. By the end, the tertiary prevention is to treat the invasive cancer at any age, including surgery, chemotherapy, radiotherapy, and palliative care.
Thank you, Dr. Diana, for sharing your experience with us. You gave a lot of information for us to think about our cervical cancer screening program, especially in low and lower middle income countries and in humanitarian settings. Now, you may ask questions from her.
Interesting presentation. And we can say that we have the vaccination in our schedule now, so I think we will reach there fairly soon in our country, so I'm really proud to say that. But that's in the school setting, so it's for the younger children. But women who haven't gotten in the past, so I'm in my 30s, so I haven't got my HPV during the school time because it's recently introduced. So it's, even though we provided MOH and Family Planning Association, it's freely available, people are reluctant to go get the vaccination. What are the strategies we can use to, I mean, there's awareness again like breast cancer for cervical cancer in Sri Lanka, but what are the strategies that we can use to bring them to get the vaccination? Even though there's awareness, they are not coming to get it. Maybe because of the stigma or related things. So do you have any idea how we can bring them to get the vaccination in our country?
Sure. So I think that the community mobilization is key for all this type of social behavior change activities that you can conduct to improve these behaviors, right? So for instance, if you have social organizations that are women-led, I think that could be a good opportunity to speak with them and from this feminist perspective, so also you can improve their capacity to be gatekeepers and to be part of the ecosystem, the health ecosystem, the public health ecosystem. So in some areas, you can use this type of connections within the communities, but also you can connect not just to develop awareness sessions inside of these groups and these peer-to-peer groups, but also maybe to have the capacity to connect them with the health clinics or the system right? So you have, I don't know, a secretary of health that is at local level, and you can, maybe the person that is at the community level talking about or doing sessions, awareness session within this group of women, and you find out that this person would like to be vaccinated, but they don't have the capacity to go because they don't have maybe the funds, the resources to, because they have to pay or something. So maybe within these support groups, they can provide this type of like emergency funds to give their peers the possibility to go to the health centers to be vaccinated. So you can do some on-demand also activities, but within and throughout these organizations. It is even best when a peer tells you what to do, not the clinical or the staff, right? The provider, the healthcare provider is even, I don't know if it happens to you, but for me and my parents, they used to review the things in Google, and they don't believe in what I'm saying. So it happens the same in the communities. So they believe in each other, and they understand what is happening, and if there are any risk due to stigmatization or stigma and discrimination, it will be easy for them to manage this type of factors.
HPV vaccination is only for 9 to 14 years. No, it's not for, and the catch-up age is up to 26. And it's always more effective for women who are not exposed to sexual intercourse. So, yes, because they would have had HPV infection once they get married or once they're sexually active. So it is recommended 9 to 14, catch-up is up to 26 years. Beyond that, it is only screening. And screening, we were doing pap smear all these days. Now we know that HPV virus detection, HPV testing is done, and that is more sensitive. So you, at least WHO says at least once a woman should be screened by the time she's 40, at least once. But HPV screening costs money, much more costlier than a pap smear. And in some countries, they send an email or a telephone call saying that you're due for your date for pap smear or HPV screening. So reminders are sent to the women to come back for their screening, because it has to be done at regular intervals. HPV virus, if you're screening, once in 5 years. Pap smear is once in 3 years.
Thank you. If I may add to what is being practiced in our country, the public health system, every woman at the age of 35 is invited to get the pap smear screening done free of charge at the MOH clinics. And then if the report is normal, they are supposed to again undergo the second screening at the age of 45 years. So 45 and 35 are the age cohorts that we are currently targeting in our public health system. Today's mini symposium, I'd like to extend heartfelt gratitude to our three panelists for their invaluable presentations, and to all of you for your being an engaging audience. Thank you. So today's discussion have illuminated complexities of addressing prostate, breast, and cervical cancers, from understanding their epidemiology, screening, and the tackling disparities, especially in lower and lower middle income countries and in humanitarian settings.